So welcome to this session entitled The Latest Update on Metachromatic Leukodystrophy, and I'm delighted to be here and share this lunch hour with you to provide you an update on screening, diagnosis, and emerging treatments to improve quality of life of patients with metachromatic leukodystrophy. This is sponsored by an educational grant from Takeda Pharmaceuticals and being brought to you by CME Outfitters, experts in continuing medical education. So my name is Florian Eichler. I'm an associate professor of neurology at Mass General Hospital in Boston. I will introduce also the other panel members here. Laura Dang, assistant professor of child neurology at Children's Hospital of Philadelphia, coming to us from CHOP, and Rachel Hickey, genetic counselor at Lurie Children's Hospital in Chicago. So the learning objectives for today are to review the impact of diagnostic delay, misdiagnosis on patients with MLD, and to really convince you that it makes a difference to make an early diagnosis, because as you make an early diagnosis, you really increase the chances for these patients to have access to more effective treatment options compared to them being in the more advanced stages. We'll be talking about how to make that diagnosis, what kinds of signs, symptoms to look out for, what kind of clinical presentation to look into, and what diagnostic modalities to use. And we will be also addressing efficacy and safety data of emerging therapies for MLD. So one of the nice things about these CME courses is you get to first frame the session and the learning by going through some questions. And the first question that I'm going to put up here is, which of the following delays in infantile development warrants suspicion for MLD? My quick comment to this and the way I look at infantile MLD is I refer to this population as the persistent toddler, or the child that really never fully learns to ambulate steadily. But I would love to have now Dr. Dang go into a classic story of late infantile MLD and explain to us why this particular option was the right one as opposed to the other options that we're all addressing earlier milestones. So, Laura?
Yeah, so this is Kai's story. It's a made-up case to really show the classic features of late infantile MLD. Typically, there are no concerns with birth or development, so Kai was born a healthy baby to Indigenous Native American parents. At 12 months of age, the child seemed to be meeting their milestones on time. He was picking up objects, eating food appropriately, saying a few words, and crawling. So you can see that gross motor development already was not robust, but really was meeting the check boxes that you need for neurologic development. Around 18 months, the family was concerned because he was losing balance, falling when attempting to stand or walk, and he was diagnosed with just developmental delay, and they were worried it could be hip-related, so he was referred to orthopedics. Within months, he became irritable, really started speaking less. So while his language had been his strength, he started losing those skills and really still couldn't stand or walk. And so what was a subtle delay 12 months prior, or really, hitting the milestones, within the next 12 months evolved very quickly to being quite a profound delay and even a beginning of a loss of milestones. He was at this point referred to neurology. Within months, he was found to be struggling to eat, swallow, and was fitted for a G-tube. And so this classic case of late infantile MLD really hits along many of the key points. Children are often referred initially to doctors that aren't neurologists, ophthalmologists, orthopedic surgeons. Those are common places for children to go. And so children with MLD are oftentimes in the medical system. They're just not being picked up yet. And so we'll go through some of the subtler signs and symptoms that we see in young children to maybe push our diagnostic journey a little bit earlier.
Yeah, great, Laura. No, this is very illustrative and really speaks to this troubling, insidious nature of late infantile MLD. Let us briefly talk about the underlying etiology and pathophysiology, and I'll have Rachel talk us through this.
Yeah, so to further frame the pathophysiology of MLD, so it's a lysosomal storage disorder that's caused by a deficiency of a particular enzyme called aryl sulfatase A, or ARSA. And this enzyme plays a really important role in breaking down sulfatides within our lysosomes. With a deficiency of this enzyme, what happens is that the sulfatides end up building up and causing tissue damage, particularly within the myelin sheath of the neurons. And this ongoing cell damage also elicits an inflammatory response, which is another component of the underlying pathophysiology of this condition. To discuss the genetic etiology, this is an autosomal recessive genetic condition that is caused by biallelic pathogenic variants in the ARSA gene, which is the gene that creates the aryl sulfatase A enzyme. At the bottom there's another gene that's listed. It's called PSAP, and this gene is responsible for making a protein that is called saposin B. And this protein is actually an activator protein of the aryl sulfatase A enzyme. And so biallelic variants in the PSAP gene can also cause an MLD-like phenotype because it results in a deficiency of the same enzyme that we see in MLD. This condition is certainly rare, but definitely one to keep on your differentials whenever you're approaching a case.
Great. So clear loss of function disorder due to an enzymatic defect that leads to sulfatide accumulation. So how does that now lead to different phenotypic presentations? And probably just to also frame this for Dr. Dang and the audience, as you heard, it's an enzymatic defect. And depending on the amount of residual enzyme activity, you see different phenotypes. Is that right, Laura?
Yeah, so I think depending on where you look in the literature, there are different ways to classify MLD. It's typically divided up in kind of semi-arbitrary age-based delineations. So there's late infantile MLD, which most people believe it's the presentation with neurologic symptoms before 30 months of age, although historically sometimes it's been classified as high as 4 years of age. There's juvenile MLD, which is somewhere between the 2.5 and 16 years, so kind of that post-puberty period. And then there's the adult form, which is anyone that presents with neurologic symptoms after 16 years of age. The late infantile form is the most common. It's also the most rapidly devastating. Children oftentimes have a period of normal development, and then over a matter of months, really have a devastating loss of first gross motor and then cognitive or expressive language skills. On examination, you can have ataxia. You can have particularly axial hypotonia and poor neck control, spasticity, hyporeflexia. Because MLD is both a peripheral and a central neuropathy, I have found the reflexes to be somewhat confusing because sometimes early in the course reflexes are absent, later in the course they can go higher, and then sometimes then again later in the course the reflexes disappear again. So really either up or down with your reflexes could be consistent with MLD. There are other things like dysarthria, where before language is lost, oftentimes children lose the ability to clearly enunciate. Dysphagia and GI motility is an early and profound problem that many children with late infantile MLD encounter. You can have, in the later stages of disease, respiratory distress, seizures, optic atrophy. But I'd also like to point out many children with late infantile MLD present with ocular motor defects, strabismus, esotropia, and it can be a subtle sign that happens before the clear neurologic regression. Unfortunately, in late infantile MLD, the course of disease is very homogeneous and it's also very rapid, where children really from their first signs and symptoms lose the ability to purposefully move and communicate within a matter of months, sometimes years, and children do have a shortened life expectancy. The juvenile form is the most heterogeneous. And more modern literature is starting to divide this not into just juvenile, but into two different subcohorts, the early juvenile and late juvenile. And that's because the early juvenile patients They have a disease trajectory much more similar to the late infantile MLD. And so they oftentimes present, again, with motor symptoms, intellectual decline, personality changes, ataxia. In the late juvenile patients, their course tends to be much more prolonged. It's a much more chronic decline, and they have a course much more similar to the adult form, which is why we're moving away as a field from just calling it juvenile, because within that category, there is two clear, distinct phenotypes of neurologic trajectory. In the adult form, we're likely underdiagnosing it, right? It's hard to pick up on some of these signs and symptoms that we see with MLD and distinguish it from other kind of neuropsychiatric impairments. And so you can get early onset cognitive impairment, personality changes, disinhibition, social dysfunction, and then also gait disturbances too. So you do sometimes get the motor dysfunction within oftentimes years of beginning to have the more neuropsychiatric symptoms. And this is the most insidious, the most heterogeneous of the population, where in the adult form of MLD, the progression is really years and sometimes even decades. And so I think being able to predict the future is unfortunately very easy in the late infantile, but the older the population, the harder and harder it is to know exactly when the changes of MLD are going to happen.
Mm-hmm. And you spoke a little bit to the prevalence already, but maybe you can expand a little bit more.
So the current prevalence is estimated to be about 1 in 40,000, which shakes out to a carrier frequency about 1 in 100. It is more common in some populations. So for example, in the Indigenous and Native American population, particularly within the Navajo Nation, the incidence is around 1 in 2,500, or a carrier frequency of 1 in 25. As Laura mentioned, this is, an underdiagnosed condition in the adult forms, and so the prevalence is ultimately probably a lot higher than 1 in 40,000. And another thing that kind of contributes to underdiagnosis is the health disparities that are observed in the underserved communities that may not bring them to a diagnosis in time.
Yeah, and I think just to also summarize the different phenotypes here, the infantile form being insidious in nature, and involving different compartments, central nervous system, peripheral nervous system, make this diagnosis very difficult to make and leading to a number of misdiagnoses. I will say the first thing I always ask about when someone approaches me in terms of first signs and symptoms of a possible leukodystrophy is I ask, what's the age of the child? Mm-hmm. And so just knowing that age is a huge marker for suspicion along this path of making an early diagnosis. But common misdiagnosis in early onset patients can be developmental delay, CIDP, cranial neuropathies, ADHD, strabismus. Again and again, we see that these patients are put on stimulants for attention deficit disorder, not unlike what we see in other leukodystrophies as well. Late onset misdiagnoses are often psychiatric disorders. Many of the patients we see have been in and out of psych wards and have had difficulties with their behavior and substance abuse. Questions around brain tumor and dementia are often there. Just to highlight here that while we are talking here about the individual patient and the individual disease, this has a much larger impact upon also families and the community and the caregivers, and does not affect simply the patient alone. And caregivers have been reporting to us in several papers now on how this is impacting the entire family, the economics of the family, the frequent hospitalizations that are requiring caregivers also to give up their employment. And so the burden of this disease goes far beyond the individual patient. This graph here just highlights also that the time from disease onset to loss of mobility is very much associated with the phenotype. Obviously, the earlier the onset in late infantile, the more rapid the decline, and the later phenotypes have a progression that is slower, but invariably progressive. And I know Laura is doing a lot of work in this realm, so we're very grateful to her for that. I'll just highlight the clinical workup here and differential diagnosis before turning over to Rachel. I think the most important aspects of history and physical is to remember the age of onset across the different phenotypes and to have a high degree of suspicion. So in the late infantile patients, it's very hard to put your finger on the exact timing of first signs and symptoms. It really creeps up on you. Often it's not just a question of recognizing early signs and symptoms, but it's also the absence of certain history. So pertinent negatives, such as there is no perinatal history of birth trauma, that should be a red flag that helps point you to a diagnosis of metachromatic leukodystrophy. So listening to that patient history closely, asking about family history is crucial. And as Laura alluded to, the exam can give you some clues, but it's difficult in the presence or absence of reflexes. While it helps identify whether peripheral neuropathy is present or not, it's not definitive in of itself. So the ancillary tests that help us probably most are brain imaging, because of certain MRI patterns that can be pathognomonic for metachromatic leukodystrophy. CSF protein might be elevated, but in of itself is not specific to metachromatic leukodystrophy. Nerve conduction studies can be abnormal, pointing to a peripheral neuropathy, but are not invariably present. Neuropsych testing is helpful in identifying what probably an astute parent already knows, which is that their child is suffering from personality changes, attention deficit. I'll turn over to Rachel to talk a little bit about definition.
About how to diagnose MLD when you're suspicious for it. And the one that's listed at the very top, the white matter biopsy, is really one that's not done today due to the invasive techniques, but it does have some historical importance in how metachromatic leukodystrophy got its name was through identification of metachromatic lipids on biopsy. What we do today is diagnose MLD through a combination of biochemical testing and molecular testing. The gold standard of diagnosis is through identification of low ARSA enzyme and elevated urinary sulfatides. Genetic testing is, of course, very widely used, and you can come to a diagnosis of MLD by finding pathogenic variants in the ARSA gene, but you will need to rely on the biochemical testing in the event that you have a genetic change that is uncertain or hasn't been seen before. And then at the bottom of that slide is a couple of scenarios to be aware of when doing the biochemical testing. So a pseudodeficiency is essentially a type of genetic change that can cause the enzyme to look low on our testing assays, but it's actually not low within the body. And so you can have a patient come back with low ARSA enzyme, but they don't actually have the condition. In a pseudodeficiency, we would expect the urinary sulfatides to be within the normal range, and so that can help give you an indication of, this actually isn't a case of MLD. And pseudodeficiency alleles are not disease-causing. The PSAP mutations are referring to the saposin B deficiency that we discussed earlier. And in saposin B deficiency, the ARSA enzyme is actually normal, but the urinary sulfatides are elevated. The reason why the enzyme level is normal is because the ARSA enzyme does not need the activator protein to break down the artificial substrate that's used on our assays. And then finally, there's a completely separate condition called multiple sulfatase deficiency, which is characterized as a deficiency of multiple different sulfatase enzymes, with aryl sulfatase A being one of those. And so testing for that condition can also reveal low ARSA activity and elevated urinary sulfatides. But with that condition, there's usually many other body systems that are affected. And there's also other deficiencies in sulfatase enzymes, so you can pick that up if you're doing some type of an enzyme panel.
Great. Thanks, Rachel. That was very helpful, informative. I'm going to take a step back and say, well, what does the imaging actually look like that would prompt you to engage in these diagnostic tests and think about the diagnosis of MLD? MLD is a classic leukodystrophy that involves white matter of the brain. Usually there's a diffuse pattern of white matter involvement throughout the supratentorial regions, often in a tigroid pattern, very diffuse in nature, sparing subcortical U fibers, different than adrenal leukodystrophy or Krabbe. It's not simply posterior predominant. It's often both front and back. And what's tricky is that in the beginning, similar to the clinical course, the MR imaging can actually look like any other child who is in the process of going through early myelination, which means you might see some abnormalities in a 1-2-year-old child in the periventricular areas that are terminal myelination zones, and you think, well, that actually would be classified by the neuroradiologist as within normal limits. But what happens then over time is what you're seeing on this slide, which is that those MRI abnormalities go from the faint involvement that you're seeing in the top left corner here to being much more pronounced. You see the ventricles enlarging, more atrophy ensuing, and that is clearly beyond the normal development and myelination that you would expect in a normal developing child. And so similar to the clinical picture, it is insidious in nature and needs to be recognized as different from other leukodystrophies that have often very clearly demarcated lesions in the early stages. This is not the case for MLD. We came up with a scoring system for metachromatic leukodystrophy that I will admit is in large part based on what we see in the advanced cases of MLD. So Laura always reminds me we actually probably need a better scoring system for the earlier stages, but we're working on it, or actually I should say that Dr. Dang is really making the biggest advances here. But just to highlight briefly that this scoring system allows you to define the different areas of the brain that are involved. We score 0 if the areas appear normal, 1 if there's some faint involvement, 2 if there's more dense white matter involvement, and then we also look at the degree of atrophy present and measure that. And so this delineation of points really gives you a sense of the anatomic involvement on an MRI, and we use a similar scoring system in adrenal leukodystrophy, and it's tremendously helpful in informing practitioners as to how advanced the disease is.
Yeah, so back to our patient, Kai. At this point in the story, he's 30 months old, and he had presented to neurology with a 12-month history of progressive motor regression. He met all of his milestones until 18 months, but really never developed independent walking, and he was diagnosed with developmental delay. He saw an orthopedic surgeon. They ruled out hip dysplasia, and because of progressive dysphagia, he had a G-tube placed. He was noted on some of his early exams to have strabismus and hyporeflexia. And so I think that that's a really key point, and one that Florian keeps on mentioning, and I agree with fully, is that the insidious nature of late infantile MLD is children are repeatedly presenting to the medical care system with subtle abnormalities, right? And unless you think of MLD, you wouldn't naturally jump to it from your exam findings, because oftentimes that first MRI is normal or near normal. You can have a transient strabismus or esotropia. You can look like you have CIDP, as mentioned before, where if you do a nerve conduction study, it shows a demyelinating polyneuropathy. There is some inflammation associated with MLD, and so you give IVIG, and the children get a little bit better, so you try it again. And now you're 6 months into the course where a child does have neurologic symptoms, and by the time that MRI is repeated, it's abnormal. And so I want to change the paradigm of thinking of MLD as just a leukodystrophy that affects the brain, but it affects the peripheral nervous system as well. And so that oftentimes in the late infantile form precedes the cerebral involvement, at least as much as we can see it.
Good. So I think based on what you've just heard, you should be able to answer this next question. At 30 months, which ancillary study would be most useful in narrowing the differential for Kai? So you all got the right answer. Few of you chose EMG and nerve conduction studies, and maybe I'll have Laura discuss that a little bit.
We had a delightfully heated conversation going into this about which one would we choose, and I think it really depends on where you are in the clinical course. I think if Kai were a little bit earlier in the course and had lost reflexes, an EMG nerve conduction study is more likely to give you a pathologic answer. And the first MRI could be normal. I think at 30 months, when he's already really starting to lose milestones, I think there's the greatest probability that initial MRI would be the most diagnostic. But I agree. I think you should get both. So I don't disagree with the 3% of people. I think either one is a good test for this. So back to Kai. In this case, there was an MRI, and you can see on the imaging, you can see that diffuse anterior and posterior white matter involvement, as Florian had described. And the diagnostic testing that Rachel described was done. There was urinalysis, they found sulfatides, they looked at ARSA activity, and it was really below the threshold of detection. And based on the MRI findings and the biochemical testing, and then they went on to make the diagnosis of late infantile MLD. And Kai's mother is currently pregnant in her 3rd trimester.
So this leads to the next question. Which of the following evaluations should be immediately performed in asymptomatic siblings of patients diagnosed with MLD? Excellent. So I'll have Rachel discuss this and move into the next slide as well. You want to kick it off?
Yeah, so definitely the gene sequencing to identify if the sibling is affected. You can also do the biochemical testing. But the pre-symptomatic screening for MLD in siblings is so important because they may have access to interventions that the proband that you identified may not have. You can also do prenatal diagnosis for a patient that's pregnant, and that's through an amniocentesis or chorionic villus sampling looking for the familial ARSA variants. But this is really reserved for families that know that they are carriers or know that they have a risk to have a child with MLD. So either by having a child that was previously affected or through carrier screening. And from looking at all of the carrier screening panels that we typically use, ARSA and PSAP are actually on the majority of those panels. And so carrier screening would likely identify somebody who's a carrier. But the one caveat with carrier screening is that they most often report out individuals who have pathogenic variants and not necessarily a variant of uncertain significance. So that's kind of the piece here of carrier screening is a screen, and it doesn't necessarily preclude you from being a carrier. In the future, and what our field is kind of moving towards, is newborn screening for MLD. And so this would be a combination of testing either sulfatides or enzyme on a dried blood spot, but that's something that certainly needs a lot more research and evaluation before it's ready for statewide implementation.
Yeah, newborn screening clearly would be ideal in terms of moving some of these treatments forward in an ideal window of intervention, but difficult to get to. So what do therapies look like? And was that me or was that you?
I'm happy to speak on it. And so we use stem cell transplant in quite a few of the neurometabolic disorders. And so it has been long questioned how well hematopoietic stem cell transplant works in MLD. And it really is variably affected in the late infantile population. I think there's a variety of reasons. We might be offering it too late because we are diagnosing kids too late. The progression is also incredibly fast. And bone marrow transplant, and Florian, you could speak more on this too, it takes a while. Some people think between 9 and 12 months before you really get full, robust restitution of that missing enzyme. And so with that catastrophically fast course of neurologic progression in late infantile MLD, waiting 12 months is really too long to wait to expect an ideal outcome from a transplant. And so most late infantile MLD transplant studies, and I really mean reports because it's never been studied in a placebo-controlled trial setting, have shown really mixed results at best. And that's true also for the early juvenile patients. I think as you get older, in the late juveniles and adults, there are some positive reports of transplant being beneficial. I think that is only in pre-symptomatic or really very minimally symptomatic individuals. And that there are some reports that doing a transplant in a child that already has more than minimal symptoms can accelerate the disease and make it worse. And so I think, again, that importance of early diagnosis is essential. Traditional stem cell transplant, if it is the right fit for the family, has major risks involved. And so things like graft versus host, you have to weigh that risk and benefit. I think there's also the major consideration of the health discrepancy and the disparity in who has eligible transplants, and that's something that needs to be considered. Not everyone has a match. There's a lot of biases in who has that availability. And there are various approaches that have been tried: mesenchymal stem cells, cord blood, traditional hematopoietic stem cell transplants. I think unfortunately for symptomatic children, the mainstay of our medication and our management is much more supportive care. So we use things like antispasmodics to help with the horrible dystonia and spasticity these children have. When they have seizures, we treat them with antiepileptics. I think you cannot overestimate how much physical therapy, occupational therapy, speech therapy, respiratory therapy can really improve quality of life. And so I think that that's a really important part of the forward-thinking healthcare. Many children require feeding tubes. So as we talked about, early dysphagia and GI motility issues plague many of our children. And so even earlier than you would expect based on their neurologic status, many of our children require G-tubes to help with their nutrition. And many of our children have assisted medical devices, things like wheelchairs, standers to improve bone health, augmentative communication devices to give children alternative ways to communicate with their family. All of these things are a really important part of the symptomatic management of MLD.
Yeah, and I think you can make a huge difference in terms of quality of life for these children and family by just offering them these different options and creating access to the different experts who are providing support here. Just to highlight briefly for those of you who might be wondering, why is hematopoietic stem cell transplantation working here and what is it actually doing? You heard very nicely in the beginning from Rachel about the pathophysiology of metachromatic leukodystrophy, that it's an enzymatic defect, that it affects myelin sheaths, axons, but also microglia and microglial activation. And we know that bone marrow transplantation has this capacity to bring in new healthy myeloid cells from the bone marrow that then develop into monocytes and can travel to brain and become new microglia. So we think that that is an important crosstalk between bone marrow, blood, and brain that I think we will now be hearing a little bit more about as we talk about new therapeutic modalities. But in order to set that up, I'm going to ask you the next question, which of the following has not been the subject of clinical trials for metachromatic leukodystrophy? And again, the question is, what has not been the subject of clinical trials? So that's what you should be picking. Ooh, an educated audience. Most of you got the answer right, that antisense oligonucleotides have not been tried in metachromatic leukodystrophy. This being an enzymatic defect, enzyme replacement is being explored in various trials, and we hear about that, as well as lentiviral hematopoietic stem cell gene therapy, and the adeno-associated virus gene therapy has been piloted in France. And I'll now turn over to Dr. Dang to lead us through these modalities.
So as a single gene enzymatic defect, there are some really exciting ways we can potentially help children that are affected by MLD, which is, as you've heard, a relentlessly devastating neurologic disease. And so people have tried a lot of different things. There is an active ongoing trial using enzyme replacement therapy. It was originally launched as a phase 1/2 study in Europe, and it was a little different with that one. That one was IV administration, and the enzyme infusion was only given every other week. Their outcomes was that it failed to prevent any motor or cognitive deterioration, and there was relatively stable peripheral nerve function. But there's an ongoing phase 2 study that has not read out, And there are some notable differences between the first and the second trial. One is it's now intrathecal, and so you're giving that recombinant enzyme through a weekly intrathecal infusion, so it is a different route, as well as twice as frequent as before. And the results for that are not released yet, so we're waiting with bated breath to see if this can help. It was a trial targeting children that actually had symptoms already, and so children needed to have some deficit in neurologic function and in gait at the time of enrollment. So potentially something promising for us to explore further to see if that can help symptomatic children.
Yeah, so a theme not unknown to the field of lysosomal disorders, where often enzyme replacement is hindered in delivery to brain because of the blood-brain barrier. And so an intrathecal approach here makes sense, and something that we are all looking for is targeted treatment to the compartment that is most affected.
And then there's also some emerging therapies, some of which are actually available outside the US. As we briefly mentioned on that question before, AAV therapy was tried by Caroline Savan's group in France to try and restore the missing ARSA enzyme. And that study really failed to demonstrate any benefit to children. But there was another study that was launched through the Italian group where they took an ARSA cell gene therapy and actually took a lentiviral vector encoding the human ARSA cDNA and introduced it through autologous stem cell transplant. So they harvested the cells from the patient, gave them the missing gene, and then gave those cells back to the patient. And so it's kind of a cool way to change the way your cells are making the enzyme and give you a boost. So it's kind of super physiologic levels of the enzyme. When they looked at both cognitive and motor impairments in the youngest cohort of kids, so both the late infantile and the early juvenile, which we sometimes refer to as just early MLD, they did show that when children were given the product pre-symptomatically or with very minimal symptoms, their neurocognitive trajectory was different than and in kind of age-matched control population. It was recently approved in the EU and is being administered, and there are several sites in Europe that are giving children with MLD this product. And so we're waiting with bated breath to see what our options are going to be in the US.
Mm-hmm. And just to highlight again that this is really building on what we mentioned before in terms of bone marrow transplantation, but with the important difference that this is not a stem cell transplant from an allogeneic donor, but these are now cells from the children themselves, so autologous transplantation after correction of the gene outside of the body. The important difference is now you do not see engraftment problems or graft versus host disease. So beyond us knowing of at what stage of disease full efficacy can occur, it's important for you to understand a little bit the pathomechanism and the biology behind this and the themes that are emerging across bone marrow transplantation to ex vivo gene therapy. So now we have a case study.
Yeah, so Olivia is an 8-year-old girl who presents to neurology with 3-month history of clumsiness while walking. She was diagnosed with ADHD 12 months ago with new onset learning issues at school related to processing and attention. They tried atomoxetine, methylphenidate, and it didn't improve symptoms. I'm going to put a warning flag on this, right? So that new onset ADHD, new onset learning disability, new onset gait disturbance, there's a theme here, right? This isn't a child that has had attention issues their entire life and they finally got diagnosed at 7. They started having problems there. And I think to your other area of expertise, adrenal leukodystrophy, again, that huge red flag of a change in neuropsychiatric status. The parents also know that she's been acting strange. So it's not just ADHD, right? There are personality changes. The way she gets along with her peers, that's different as well. And she just seems to be a different child recently. Again, that's a flag. When a family tells you a child has ADHD, probe just a little bit more into that. Has their personality changed in any other ways? I think you can oftentimes find out, I need to look a little bit further in this case. This seems like it's not just an attention deficit disorder. This child went through the recommended panel of testing and was found to have MRI consistent with MLD, positive urinary sulfatides, low ARSA activity. And so this would be a case of juvenile MLD.
Yeah. And note on the MRI here that you see this tigroid pattern in the supratentorial regions. That's often something that we see in metachromatic leukodystrophy. It's not specific to this disease alone, but it can be an invaluable clue. So I guess we're jumping to the next question here. Which of the following is an early sign of juvenile MLD in school-age children? 100% of you decided on behavioral personality changes. I'm going to just, for the sake of argument, discuss with Laura whether resting tremor is such a bad answer to this question.
Oh, man. Yeah. So I think it possibly could be. There can be some, both you can get a tremor from the peripheral neuropathy. These children can be quite ataxic. So yeah, I think it could be possible that you would see a resting tremor.
Yeah. So white matter disorders affect multiple systems because they affect all this connecting fiber. So harder to often pinpoint just one system that it affects alone.
Yeah, so I think our last case study is one to illustrate what the latest form of MLD or the adult onset form looks like. This is a case of a 32-year-old woman who presented to actually gastroenterology from the ED with severe vomiting, bloating, and right upper abdominal pain consistent with cholecystitis. She had a medical history that was significant for bipolar for the last 10 years, according to her husband, and really a history of inappropriate, unpredictable behavior with increasingly frequent bursts of aggressiveness. They tried a lot of medications, and really nothing was helping her at all. So they did a gallbladder biopsy, and the pathology actually, post-cholecystectomy, revealed an accumulation of macrophages with metachromatic material. And so you can actually get gallbladder involvement in MLD. I don't think we have a great idea of what percentage of kids or even adults it affects. Many kids, if you do a gallbladder ultrasound, will see gallbladder sludging, but the real risk is actually gallbladder tumors. You can get carcinoma in some cases with it. And so as we're moving into potentially a world where MLD is treatable, I think things like gallbladder and long-term sequelae of having MLD are really important to monitor, because I don't know how well an enzymatic intervention that's targeting the brain is going to help things like the gallbladder. So I think these are things that are really important to monitor. This patient, Marta, was referred to neurology for suspected MLD, and she and her spouse have 2 children, ages 5 and 7.
So that leads right up into the next question, which is, what chance do Marta's children have of inheriting her pathogenic ARSA genetic variants? So we actually got some variety here. So I think this is a nice opportunity for Rachel to weigh in and explain some of the genetics here.
Yeah, and this question is worded a little confusing. So Marta will always pass on a genetic change in the ARSA gene to her children. So all of her children will be at least carriers. The chance for her children to have actually have MLD would be dependent on her partner's carrier status, which I think leads into the next question, and I may have given it away.
What would be the appropriate next step to clarify the risk to Marta's children for developing MLD?
So I did give it away. So you would do testing for Marta's spouse, although I don't think it's unreasonable to consider urinary sulfatide screening in her children, especially if you have a really anxious parent. Marta very clearly has an adult onset form of MLD, but it's possible that her spouse could be carrying a more significant pathogenic variant in the ARSA gene that could cause a juvenile presentation in one of her children. So definitely testing of the spouse is probably the best next step, but again, just kind of dependent on how nervous your patient is.
Thanks, Rachel. How do you think about timing here, and in terms of sending out these tests and how quickly they come back?
Genetic testing takes around 3 to 4 weeks to get back, whereas the biochemical testing is a lot quicker, usually closer to around 7 business days, depending on which laboratory you use. So the biochemical testing will always give you a quicker answer, an answer faster than doing the genetic testing.
Yeah, I know in some other leukodystrophies, timing is often of the essence, and we will often choose the test that will give us the most rapid answer, despite us knowing that there might be some more detailed or definitive genetic testing available. So it's important to consider clinical context in this scenario as well. So we've reached the part where we're really trying to wrap up some of the learnings here and address some of the SMART goals that have been defined here and are outlined. I hope that you've been able to, through this learning, address specific, measurable, attainable, relevant, timely goals for this population, because this is a population where you can make a difference with early diagnosis. And I think the challenges we've outlined are that depending on the age of presentation, there can be a more insidious course, or there can be clear new symptoms and regression and new onset of symptoms that lead you to the diagnosis. The other point to make is that the constellation of different symptoms can also give you the clue, whether there's gallbladder involvement, whether there's peripheral nerve involvement. All of that enhances your suspicion. So I hope you can now recognize clinical signs and symptoms indicating suspicion for MLD early in disease onset. I say, as a child neurologist, the best advice I can give you is, with a child of a certain age, just be paranoid. And that sort of helped me make the diagnosis early. And it's often otherwise very hard to put your finger on one specific constellation of symptoms. You should have learned to perform differential investigations and confirmatory testing, and you heard very nicely from Rachel and Laura on those various modalities to achieve definitive diagnosis of MLD, how to think of the enzymatic defect and the sulfatide accumulation in relationship also to genetic testing, how to screen family members of patients with metachromatic leukodystrophy for pre-symptomatic disease and or carrier status, knowing well that this is an autosomal recessive disorder where you need 2 copies of this defective gene in order to manifest. You've learned how to implement supportive management for patients with metachromatic leukodystrophy to optimize functioning and patient caregiver quality of life, thinking about the nervous system, about spasticity management, seizure management, but also about other systems that are frequently involved. Caregivers worry a lot about the respiratory problems that patients have, and often here providing the appropriate help with managing secretions can provide a lot of respite. And lastly, to explore emerging options in MLD diagnosis and disease management. It's a very exciting time in genetic disorders, and we're really on the cusp of being able to bring very effective treatments to these patients. And so we're extremely excited to see some of these trials come about and have early glimpses of success. So please keep an eye out for these children, knowing well that there are treatments emerging, and they're going to be far more effective in the early stages of disease compared to the more advanced stages. So I think now we have time for questions and answers, and please don't be shy, and let's see whether I have any questions up here. Great, so the first question, and maybe I'll direct this to you, Laura. How much hematopoietic stem cell therapy, how much does hematopoietic stem cell therapy address the peripheral neuropathy in late infantile metachromatic leukodystrophy?
Yeah, that's a great question. I think it has mixed, so the question is how much does the transplant help with the peripheral neuropathy? I think it's been really mixed evidence that it helps. And in fact, some show that the disease and your loss of motor skills will relentlessly progress. And so I think it helps less on the peripheral neuropathy than the central in the ambiguous cases where it might show benefit. I think timing is important. Again, it's treating and giving an intervention before there's fulminant symptoms. We fail in many cases to reverse injury. I think preventing injury is a much easier thing to do. And oftentimes, by the time you've diagnosed a child, they already have fulminant peripheral neuropathy. And that may be the difference on the kids, that it has more or less benefit to their peripheral nerves, is really where in the course of the disease and the demyelination you are.
Great. Are there any predictors of who will develop these different phenotypes?
There are some genotype-phenotype correlations, meaning that if you identify a specific genetic change, it may direct you to saying this is more likely going to be a juvenile case. I think that's more helpful when we're thinking of pre-symptomatic testing, although of course if you have somebody who is of juvenile age presenting with these symptoms, it's going to lead you to say that this is probably a case of juvenile. But a lot of the variants in the ARSA gene are not known, or we don't have a good correlation as far as what they will ultimately cause, and that's just because of the combination of the two genetic changes. We just don't have knowledge of all of the potential combinations.
Yeah, and similar to other lysosomal disorders, there is some correlation with residual enzyme activity and the degree of function and you will attain. Maybe a related question for Rachel that we partly addressed before: is neonatal screening available for MLD? And maybe just
as a newborn screening?
Yeah.
It's not widely available. There are assays that are being investigated, but it's not something that we're doing right now.
Okay. So both age at disease onset and predominant clinical presentation are not specific enough to differentiate between infantile and juvenile. How much do they have overlap in real practice?
Oh, that's a hard to answer question. So the line between the early onset forms and the late onset forms are much clearer than the nomenclature makes it seem, right? The vast majority of the early onset form of MLD presents before the age of 2. Right, so it is not as much of this slurred bell-shaped curve of presentation. There is a huge peak of approximately 60 to 70% of the cases we know of presenting really before the second birthday, right? And that's why that border zone between late infantile and early juvenile was moved from the 4 years to 2.5 years, because that really covers the vast majority of the cases. I think the challenging ones are the cases that present with predominant motor symptoms and very rapid regression, at the age of 3. Those cases are most likely going to be in clinical practice, behaving and trajectory and complications very similar to the classically infantile ones. Whereas a 7-year-old that has neurocognitive deficits, the personality changes, like that second case of the juvenile case, that is most likely going to be a much slower adult-style presentation, with the caveat of until gait is affected. And there is a lovely study by German Leukodystrophy where they looked at the rate of motor regression, so loss of ambulation, and how fast the change happened once you started losing skills. And while the juveniles oftentimes have a much longer period of neurocognitive issues, making their overall course longer, once the juvenile patients start having difficulty walking, that trajectory is still very fast, right? And so I think that's a really important thing to understand, that really once motor skills are affected, the trajectory is really quite accelerated. It's just the signs and symptoms and that period of that lead-in, that window for potential intervention is different between the groups.
Yeah, so I completely agree. I think the challenge in the juvenile phenotype is that variability and heterogeneity that makes it really challenging. The infantile patients are really have a very stereotyped course, and while there are those patients that might be hard to categorize if they're beyond 2 years of age or right at that cusp, the vast majority of late infantile patients behave the same way. I remember having triplets with metachromatic leukodystrophy, late infantile form, and literally they came in with the same esotropia in their right eye, weeks apart, started having seizures just months apart, and then ended up passing away within months of each other. So there's some systematic biology here with the late infantiles that's really harrowing and difficult to watch. But the heterogeneity in the juvenile patients is difficult. I usually say to families, the best predictor of the future is the past. So if you see what has happened in the past few months, it might help you get a sense of how quickly this is moving. But I agree with Laura that it's often very hard to predict this heterogeneity in the juvenile patients.
And to the end of the question of genotype-phenotype correlation, when you look at sibling pairs, like the unfortunate sibling pair you described, when you have late infantile form, the siblings all present at the same time and have the exact same trajectory. But that's in part because late infantile or early onset MLD is very homogeneous, right? And that the older your sibling pair is, the more different it is with age at onset, right? So the early juveniles tend to have a very tight cluster where they present within months of each other, whereas the late juveniles or the teenagers, they can be years between a sibling pair. And so I think we're much better at predicting disease course the younger the child is.
Very good point, yeah. So Rachel, here's a question for you. When a spouse is also implicated as a carrier in the example highlighted, is there a benefit to knowing status of the children related to potential onset of MLD?
So if a spouse is found to be a carrier, in the case where we had an adult patient, and is the question, is it useful to know the children's status?
Yeah, I think it comes back to
I think
what
Laura
was
kind of
talking
answered
about.
it a little bit. It certainly is, and I definitely would advise testing for those, for the children. Of course, then it's hard to predict if they'll look like their mother with the adult onset condition. And even if they do have the adult onset condition, when are they going to have symptoms? And that's something that they'll need monitoring for. Very few cases of genotype-phenotype correlations give us a very clear roadmap to when we can expect symptoms to pop up.
So here's a question on AAV-mediated gene therapy. What is the current status of adeno-associated viral gene therapy for MLD? Maybe Laura, you want to take a stab?
So I think the most active area of the MLD gene therapy research is the product that is based out of Milan, which is the non-AAV. It's a lentiviral one with the autologous stem cell transfer. And they have an open juvenile study on now that is actively enrolling, I believe. And so I think that's the biggest status that I know of, and the only open trial for gene therapy.
It's still an ex vivo gene therapy lentiviral.
Yeah.
Yeah, so the experience with AAV-mediated gene therapy that was conducted in France was a direct stereotactic intracerebral injection of AAV, where despite being able to lower sulfatides and show enzymatic activity in CSF, unfortunately the gene delivery did not bring clinical benefit to patients. And it's not quite clear why that's the case. People think in part that it was because of an inflammatory reaction to the AAV administration, but it's difficult to know, again, whether disease status and stage of disease was also a limiting obstacle. So maybe a related question here, Laura. Theoretically, could enzyme replacement and ARSA cell gene therapy be used together?
Yeah, I think it's a really interesting question. We know transplant takes really too long for late infantile or early onset MLD, but gene therapy isn't immediate either, right? So it still takes several months to get restitution of the missing enzyme. And so is it possible you could do enzyme replacement as a bridge until you can manufacture that individualized, personalized medicine product, which takes around 3 months, right? And then while you're waiting for it to work, could you continue the enzyme therapy? Maybe. I think it's a great idea. We think of these very complicated metabolic disorders that are from a single gene as needing a single answer, a single fix. Whereas things like cancer or diabetes or hypertension, we don't think twice about using multiple products and therapies to try and help someone. And so I think we will become less focused on single approaches and start diversifying what we offer to families. I think one step at a time, let's get some therapies on the market and be able to help families. But yeah, I envision a world that we tailor and individualize the treatments we can offer to families based on the signs, symptoms, the speed of the disease, where they are in the disease course. I love that idea. Let's do it. Let me get some products first, though.
Yeah, combination therapy is probably where the field is going overall. We're seeing some of this also emerge now in the field of Krabbe, where there is bone marrow transplantation being combined with AAV gene therapy. Everybody knows of the spinal muscular atrophy field, where we have antisense oligonucleotides and now AAV9 gene therapy emerging and often competing, but maybe also coming together at the right treatment times. I think what is often overlooked, what is a wonderful opportunity for child neurologists, is to think about the underlying disease biology and the change that's happening, and understand how we can open up that window of intervention. As Laura was saying, what if enzyme replacement gave us an opportunity to extend that window a little further so that we have more time to effectively come in with an ex vivo gene therapy. So these are all things I think in the coming years we're going to need to address. Question for me here specifically: can I comment on correlation of MRI severity scoring with disease severity compared to volumetric studies of gray and white matter? So I think I want to point out before I answer this that there are some important differences in the MRI lesion development in MLD compared to other leukodystrophies. Here, similar to the clinical course, the lesion is very insidious, and at the time when first symptoms emerge, the MRI is often not that abnormal. This is very different from adrenal leukodystrophy, where you clearly see lesions develop before signs and symptoms emerge in the children. So I think one has to take all attempts at correlating MRI severity scoring with clinical course with a grain of salt, because you have to understand that these are not necessarily evolving at the same time point. I think the clinical in MLD tends to be a little ahead of the MRI changes, whereas in ALD it's actually the reverse, that the MRI is a little ahead of the clinical changes. And so knowing that first and foremost is important, so that you're not comparing apples to oranges. I think the MRI severity score, as we devised it, is very much leaning on also ascertainment of atrophy, and so it would, in my mind, likely correspond and correlate well with volumetric studies of gray and white matter. This is, however, mostly in the advanced stages of MLD. I think we are still struggling, I think, to come up with good early markers of disease progression on imaging. But in terms of a readout of late stage and expected outcome, I think both the volumetrics and the severity scoring system are going to be helpful.
I mean, I've seen the early MRIs be read as normal and really just have those slightly brighter terminal zones of myelination that, are within the range of normal. I've also seen isolated cranial nerve enhancement. It likely is correlating with when you see the strabismus or esotropia, like the ocular motor defects that are coming on. And one thing that I'd like to point out is oftentimes that disappears, both the cranial nerve involvement as well as the ocular defect. And I have met many a child that has presented with an ocular motor defect, gone to ophthalmology, had the surgery scheduled, and in their pre-op examination, the strabismus was gone, right? And so it's because it's the inflammation that's happening as part of the MLD early process.
And this is something you can see in Krabbe leukodystrophy as well, where you also see this sort of also swelling of optic nerves and other cranial nerves. And I completely agree that that can coincide with enhancement. different than what you see in adrenal leukodystrophy, where there's garlands of contrast enhancement, blood-brain barrier breakdown that you don't see in metachromatic leukodystrophy, right?
Yeah, I think one of the very useful things about ALD, as you mentioned, is that the imaging precedes the clinical change. And so that means the MRI can be used as a really good screening tool for children identified through newborn screening. And I think as a community, we'll need to come together to figure out the best way to screen children with MLD, because I don't want to wait for the MRI to change. I would like to potentially offer an intervention before the MRI is changing. And so I think that that's a challenge with some of our disorders like Krabbe and MLD, where the cerebral MRI changes are happening after the child changes. They're of less help. We want to intervene to help children before they have problems, not after they've started having difficulties.
So I think that actually very nicely addresses the next question, as I'm seeing us run out of time here slowly. Is the gene therapy for MLD only provided after symptoms develop, or can it be provided asymptomatically?
Yeah, so it can be in Europe, and as part of the trial, you could be pre-symptomatic. I think with our current ways of diagnosing MLD, you're limited to people that unfortunately had an older sibling that was affected and passed away from the disease. That's the way we find out that a younger sibling is affected, and also the way we know very clearly what subtype of disease they would have. And so I think as we move into newborn screening, we're going to enter into an era as a community where we'll need to figure out genotype-phenotype correlation, really define who needs intervention and when, because again, pre-symptomatic intervention is our goal, but you wouldn't want to do a very invasive, potentially life-threatening intervention if maybe the penetrance of MLD isn't what we think it is, or you have an adult onset form. And so I think we have a lot of things to refine very quickly as a community. And so I'm glad you all attended, because now you're MLD experts too. And we can work together to better help this community of families that is really desperate for a treatment and really deserve our full efforts.
Yeah, so I think big take-home message is that strong genotype-phenotype correlation, at least for the infantile patients, and why Rachel's work is so important as she's counseling families. This is very different than adrenal leukodystrophy, where we are not in that position to say, genotype-phenotype correlation will tell us what the sibling will have, and there's a lot of discordant course. So I do think that it might help us in terms of the appropriate timely treatment when we know of other family members, and I think that's also your experience, Rachel. Right?
Knowing of other family members, then also just being able to review the literature and see what's been published. I think we need a better way of collecting information about the MLD phenotypes that we see in correlation with those genetic changes. All of our groups have MLD patients, but have we all published on their exact genotypes and what their phenotypes look like? Probably not, although you guys may have, but we certainly haven't. So that's definitely the next step, is to get that data out there and available so that it can be useful when you're looking at someone who's pre-symptomatic.
Nice call to action here. Last question here. How much does it affect our approach to the patient if we perceive that the clinical findings of a patient with a borderline age of 2 years old has juvenile MLD instead of infantile MLD? So this is coming back to that earlier question. Clearly, I sense there was a challenging diagnosis here. But can you speak to that a little bit, Laura?
Yeah, so at this point, if the child were born in Europe and had access to the gene therapy product, having either what would be classified traditionally as late infantile or early juvenile would both potentially qualify, as long as they had minimal symptoms affecting their motor systems and cognition. And so that line in the sand matters a little less, because they behave very similarly. I think as we have new products on the market and new trials that are emerging, really understanding the enrollment criteria is going to be critical, and understanding, is a child that presents at, 2 years, 7 months, really different from a child that presents at 18 months, and figuring out predictive variables or prognostic variables that help me to better understand. So we're working on it.
Yeah. I mean, in the end, it's about preserving function and knowing that you have quality of life, and you're intervening at a time when you can preserve something, regardless of whether you're infantile or juvenile. So I hope that helps guide this. So we're at the end of our time, and thank you for all submitting such thoughtful questions, and delighted to have had this opportunity to discuss things with colleagues dear to me. So this now ends our session. To receive CME credits for this activity, participants must complete the post-test and evaluation online. I'm convinced, given all your answers, you're going to do terrifically on this post-test. So go to the evaluations tab and click on the link to complete the process. Thanks, everyone.